I think we should start. Good evening, everybody. On behalf of Africa Healthcare Network and on behalf of Dr. Lloyd Vincent, Chief Medical Officer, Africa Healthcare Network, I would like to welcome you all into today's webinar organized by Africa Healthcare Network. And today's series number 9. So my name is Dr. Egina Francis Makwabe. I'm the consultant nephrologist and physician and Chief Medical Director of Africa Healthcare Network in Tanzania. So today I'll be coordinating this webinar together with Dr. Jonathan Wala, who is a consultant physician and nephrologist of Aga Khan University Teaching Hospital in Kenya. And today's topic will be it's called the top 10 discoveries in nephrology. And this topic will be presented by Professor Anupam Agarwal, who is an MD and FASN, and he's the current president of American Society of Nephrology. So I would like to request Dr. Wara Jonathan to present the bio of Dr. Agarwal, and then after that, he will welcome him to continue with the presentation. Dr. Wara, can you please present the bio of Dr. Agarwal?
Thank you very much, Dr. Makwabe. Welcome everybody to an inviting session because we have an eminent nephrologist, a very good teacher, Dr. Anupam Agarwal, who is the current president of the American Society of Nephrology, which most people are involved in. He's the director of the Division of Nephrology at the University of Alabama at Birmingham. And in the same university, he's the executive vice chair of and vice dean in the School of Medicine. He has put many hats he's wearing. He has an active role in clinical medicine, in teaching, in research, and even in administration. He's an recipient of multiple awards, very well and widely published, has written several authored several chapters in different books. And his best research is
Dr. Wala, your voice is hardly audible.
You can hear me?
Yes, we can hear you. Can you proceed, please?
Okay. He has interest in research in for instance of the mechanism of acute kidney injury. He enjoys golfing, gardening, watching his favorite college football team, and apart from that, he's an enthusiast in playing Indian classical violin. So with the same enthusiasm and with the same finis, I'm sure he's going to present the 10 most important developments in the world of nephrology. Welcome, Dr. Agarwal.
Well, thank you very much. Can you all see my slides?
Yes, we can.
It's very clear, very clear. Thank you, Dr.
Very clear, great. Well, thank you for, hang on. Sorry, I think, for some reason I lost the screen, just a minute.
No problem.
There we go. Can you all see the slides now?
Very clear, very clear.
Right. Well, thank you very much for that kind introduction, Nikki and Nikhil and Lloyd Vincent. I really appreciate the invitation, and Dr. Makwabe and Iwala, I really appreciate you inviting me to do this. And I have a presentation that I prepared, but really I'd like to leave a good amount of time for questions and really have a open dialogue, on any of these topics or any aspects pertaining to nephrology. I'll begin with some of my disclosures here. I'm advisory board on some companies, as well as a review from the NIH and the VA here, but none of the topics I'm going to be presenting have any relationship to these disclosures. I'll begin by just addressing, we are all facing this COVID-19 pandemic, and it's just unprecedented. Who would have thought January or February that we would be in month 6 of this, pandemic? And as you know, the US is going through an unbelievably hard time with over 5 million cases, 170,000 deaths, and the unemployment, the effect it's had on our society has just been tremendous. And more importantly, all over the world, I think it has been just shocking. And to add to that, all the issues that we faced with more recent, killings of George Floyd and Ahmaud Arbery and Breonna Taylor and others at, police brutality, that has just added another layer of really an unprecedented movement, in the United States. So hopefully there'll be good things that come out. And I wanted to highlight this paper by my colleague at Indiana University, Rajiv Agarwal, who really turned things around that, yes, we are going through this pandemic, but look, what are the good things this has brought to our field as nephrologists. And some of these we clearly need to keep as we go forward. We've collaborated in ways that are really unprecedented. Innovative things have come to the forefront. I don't know how it's in Africa where you are, but in the US, telemedicine is now central in how we take care of patients. Delivery of dialysis, virtual learning. We're doing this webinar, through Zoom, and really the breadth of the reception. I just participated in the Japanese Society of Nephrology annual meeting earlier this week. I was supposed to be in Tokyo, but we did it virtually, and there were over, thousands of people that could participate just because of the virtual nature of the meeting. Clearly, it has helped us prepare for disasters, infection control. It has highlighted how disparities occur and social determinants of health are so important in us, taking care of, patients. And obviously research, it really opens the door for research. So I think, every cloud has a silver lining. So I think we will get over this pandemic at some point, whether it is this year or spring or summer of next year, we will get away from this. So clearly we would have learned a lot from this, and we would tell our kids and our grandkids, how we went through this. So I think we should take it in that spirit for us as nephrologists as well. So I prepared a list of top 10 discoveries in nephrology over the past few decades that I think, really transform nephrology and our specialty. I use this talk to really encourage undergraduates, high school students, and others, to really explore the field of nephrology. I'm sure you are aware that in the US, the number of people interested in nephrology careers is declining, and we need to change that trend. And I'm not sure what the workforce is for nephrology in Africa, and what the interests of medical students and others is to pursue nephrology. But I use this to really stimulate people that there's a lot of excitement in our field, that we need to spread this as we do rounds, taking care of patients or doing lectures to medical school students, that there is excitement in our field. So I'll go over these, very briefly in a few minutes for each of these. So when you look at the number of randomized clinical trials in nephrology and you compare to the other specialties, am I coming across okay in terms of sound and the slides?
Yes, absolutely okay.
Great, thank you. You can see that, our colleagues in neurology or cardiovascular medicine or infectious disease or cancer have a lot more clinical trials. And we are at the bottom here in this green line. It has improved a little bit in the last 5 or 6 years, but I think we clearly need to do better. And I think things are going in that right direction. So let's talk about this SFLT1, in preeclampsia. And a lot of these discoveries I'd like to highlight. The lead person was a trainee, was a fellow or a resident that really led that effort, and that led to a real seminal discovery. So in selecting these top 10, that was foremost in my mind, was a trainee involved in that discovery. So we know preeclampsia, the syndrome that affects 5% of pregnancies, substantial maternal and fetal mortality. And before this paper, we didn't know what the pathogenesis was. We knew it was endothelial injury, vasospasm, platelet activation, prostacyclins, and so on. And everybody knows, you all take care of patients, that the placenta was the key culprit. You take the placenta out, everything is fine. The mom, completely reverts back to normal. So here's a schematic just to show that, maybe there are genetic factors, environmental factors that lead to placental dysfunction. And there may be some circulating factors that essentially are elaborated by the placenta that cause vascular dysfunction, blood pressure increase, kidney failure, cerebral edema, seizures, and then liver dysfunction. So what these investigators did in this paper that was published in the Journal of Clinical Investigation was they identified this protein, soluble FMS-like tyrosine kinase 1, as contributing to endothelial dysfunction, hypertension, and proteinuria in preeclampsia. So how did they do it? So they took patients with preeclampsia, and they had normal, healthy, normotensive pregnant women. So they took the placentas from those women, the two groups, and they did a microarray analysis. And then they used an animal model of pregnancy to see if what they found in humans actually translated in the animal model. So they did gene expression profiling on the placental tissue, and they found this protein SFLT1. So here's the data. So you can see here, N1 is a normal, N2 is normal, N3 is another normal person, and P1, P2, P3 are 3 placentas from pregnant women with preeclampsia. You can see this massive increase in this protein, SFLT1, only in the preeclamptic patients. And if you look at the serum level, so this was in the placenta, if you look at the serum, you could see, based on the severity of preeclampsia, mild or severe, the levels of SFLT1 were markedly elevated in preeclampsia compared to controls. What they did was they took SFLT1 and put it in an adenovirus and injected it into an animal model. And they found when they injected just the control, nothing happened in the kidney. But when injected into the pregnant animal, they injected SFLT1, you could essentially recapitulate the lesions of preeclampsia. And not only that, these rats actually develop hypertension and proteinuria as well, which is a hallmark of preeclampsia. So really a great way of reverse translation where you find something in the clinic and you take it back into an animal model and demonstrate that it is recapitulated. Subsequently, they published a nice paper in the New England Journal of Medicine looking at these circulating angiogenic factors. And the key result from that paper is shown on the slide here. You can see the blue bars are control women during pregnancy, and the red bars are women that develop preeclampsia. But what is more important is the levels of this SFLT1 on this y-axis started to increase much before these women develop preeclampsia. So it's a great biomarker to say you're likely to get preeclampsia if your SFLT1 levels start increasing. So not only is a biomarker, but it is pathogenic in preeclampsia. So really a seminal discovery that occurred. And the person who actually did this work was Sharon Maynard, that I had a picture of on the first slide, and who was a renal fellow at that time when this work was done. So we'll move on to PLA2R in membranous nephropathy, and I'll talk a little bit about what this is. So again, just like preeclampsia, membranous nephropathy, very common cause of nephrotic syndrome. We knew it was antibody-mediated autoimmune disease. It's characterized by subepithelial immune deposits, and the target antigen till this work was not known. Nobody knew what the antigen was that developed this autoimmune response. So this work, again, done by another renal fellow, Dr. Lawrence Beck, in the lab of David Salant. By the way, David Salant is originally from South Africa. And he showed that this M-type PLA2 receptor was the primary target as the antigen for idiopathic membranous nephropathy. So very simple experiment. They took serum from patients with membranous as well as glomerular extracts from biopsies. and showed that only in membranous nephropathy, this 185 kilodalton protein was massively increased. And other causes of nephrotic syndrome like FSGS, diabetic nephropathy, this protein was not detectable. And they did staining for this protein and found that only in idiopathic membranous nephropathy, shown here in the red, this protein co-localized with IgG. And a patient with lupus membranous did not have this. So really specifying that this protein was clearly indicative of just idiopathic membranous nephropathy and not secondary forms of nephrotic syndrome from lupus and so on. More importantly, these antibodies to PLA2R actually correlate with disease activity. And this is shown on this slide from really nice work that was published in 2016 in a review article. You can see that the glomerular deposits are much lower and they start later in the disease process, but the serum levels start about the time patients start developing proteinuria. And the immunological activity, the clinical disease, it also correlates with the remission. So if your levels go down, you can say that the patient is going into remission. So not only is it pathogenic, but also serves as a biomarker and tells you whether or not you're going into remission. So important biomarker, 80% of the patients, so that's a high number. It's highly specific for membranous nephropathy. You can monitor disease activity. You can predict a remission or a relapse. And presence of PLA2R after transplantation actually can suggest a high risk for recurrence. So let's move to ApoL1 in kidney disease. And again, this is, for me to tell you this story is like bringing coal to Newcastle. So forgive me for this, but I'm sure there are some newer trainees in the audience. So I will just go over this very quickly. So this work again was done by a trainee, Dr. Genovese, who published this paper in Science, demonstrating that this trypanolytic ApoL1 was important in why African Americans have more kidney disease. So again, we know that Trypanosoma brucei causes African sleeping sickness, and gene variants of this ApoL1 essentially increase resistance to Trypanosoma brucei in Africa. However, variants of this gene increase risk for kidney disease in African Americans. So what was found subsequently to this work, and there are two alleles, G1 and G2, and the G1 and G2 actually is named after the first author of the paper, Dr. Genovese. So just to give you a background on that. Subsequent work by Kathleen Shustak and others essentially took that human finding that if you have those G1, G2 variants, if you make an animal model with this, can you mimic what occurs in humans? And that was actually precisely the case. So shown here, where Dr. Shustak and her colleagues overexpressed even the G1 allele or the G2 allele. And you can see in the middle and the right panels, classic features of podocyte involvement and FSGS in these animal model with overexpression of the G1, G2 compared to what you see on the left, a completely normal glomerulus. So again, a great finding in the clinic that has been reproduced in the humans. And currently we're doing a large study in the US called the Apollo study that is looking at outcomes of these ApoL1 variants. So if a donor has these variants, should we not consider transplanting those kidneys? Or if a recipient has these variants, should we reconsider transplantation? So that large study is currently ongoing in the United States. So peptide inhibition of FLC-THP, which stands for free light chains and tam-horse protein for myeloma kidney. So a colleague of mine at my institution, Paul Sanders, had described that myeloma affects the kidney through cast nephropathy. And you can see these classical fractured casts in the tubules. And this is the cause of acute and both chronic kidney injury. And this was a rodent model that he had published. So what they found that if you inhibit the interaction between the free light chain and the tam-horse protein, you could essentially block the development of cast nephropathy. So that is schematized here in the green little rods you see here is free light chain. So anybody with myeloma, the plasma cells are preparing more free light chains. And these free light chains get filtered in the kidney and they clog up and cause, they interact with this blue circles here and cause cast nephropathy. These blue circles are TAM phosphol protein. So he found the structure that causes the TAM phosphol protein to stick to free light chains and developed a peptide that would block that inhibition. So when he did that, you essentially block this interaction and you actually rescue these animals from getting cast nephropathy. So there are clinical studies now ongoing with this inhibitor, currently looking at how this can actually go into clinical trials. So really remarkable discovery from basic science, understanding the structural interaction and taking it into the clinic. So we'll talk about NAD metabolites, for kidney treating AKI. Also, feel free to ask me any questions if you have. You can post them in the chat box, and I'm happy to address them as we go along. So NAD metabolites in AKI. Again, the work of Samir Parikh and others had demonstrated earlier that this protein in the mitochondria called PGC1 alpha was really critical for renal protection by regulating mitochondrial biogenesis. And in the mouse model, they showed that this mitochondrial regulator called PGC1 alpha was really important for regulating NAD biosynthesis. And essentially, if you treated with the precursor for this NAD, you could reverse established AKI. So they showed in this paper in Nature Medicine, in humans actually, that if you give NAD and you reverse this impairment of NAD biosynthesis, you can reverse acute kidney injury. And the nice thing is you can actually buy this in the store without a prescription, very cheap, and essentially niacinamide. So what they did was they gave 2 doses in addition to placebo, 1 gram or 3 grams, to patients who were undergoing cardiac surgery and were at high risk to get acute kidney injury. And you can see here placebo in the red, -1, 0, and 1 day prior to surgery. And with surgery, they get the bump in their creatinine. But the patients that got 1 or 3 grams of the drug, NAD, essentially were protected from AKI in the setting of cardiac surgery. So really elegant and a very effective and cheap mechanism. So now doing larger studies actually, and I know that Dr. Parikh is also looking at COVID and AKI, if this NAD can actually be used to protect the kidneys in patients who are in the intensive care unit with COVID. So let's move to circadian rhythm and cardiorenal function. So the circadian clock is really important in regulating a lot of different functions in our body. And Michelle Gums, she was actually a graduate student in the lab, and I was at the University of Florida in the lab of Dr. Wingo, found that within the kidney, this protein, period 1 or PER1, regulates expression of sodium channels in mice and actually also regulates not only sodium excretion, but also blood pressure. And since that work, almost 11 years ago, there's been a lot of buzz on the circadian rhythm. And we know in 2017, the Nobel Prize in Physiology or Medicine was awarded to 3 investigators, Dr. Hall, Dr. Rashbash, and Dr. Young, for their study of understanding the molecular mechanism of controlling circadian rhythm. And now there's a lot of work on what time you eat, how that relates to developing obesity or diabetes or hypertension and progression of kidney disease and so on. So there's a lot of focus on this field of circadian biology, and it has opened a new avenue for investigation. So let's talk about SGLT2 inhibition in diabetic kidney disease. So this has been a huge landmark breakthrough for us in the field. This was presented last year at the World Congress in Nephrology in Melbourne. Multiple SGLT2 inhibitors are available now on the market, and canagliflozin was one of them. And this is a paper in the New England Journal, the Credence trial, essentially showing that if you gave patients with diabetic kidney disease canagliflozin as an SGLT2 inhibitor, you could actually reverse progression of kidney function. You can see here the placebo in the orange bars and the canagliflozin in terms of preserving kidney function. Here's the top bar is albumin creatinine ratio, and the bottom bar is eGFR. Significant reduction in albumin creatinine ratio, as well as improvement in the eGFR in these patients that got this drug. So remarkable accomplishment that we have seen. And now I hear this drug also benefits non-renal complications of diabetes, for example, in the heart, and may also have effects in non-diabetic kidney disease. So really remarkable finding from these clinical really pioneering clinical studies. On a similar note, another drug, endothelin A antagonists, have also been shown to be of value in diabetic kidney disease. And this was also published last year in the Lancet, the SONAR study, where they used an endothelin A antagonist, atrasentan, and shown in a double-blind randomized placebo-controlled study that this actually improved renal events in patients with type 2 diabetes. So we now have not just insulin or ACE and ARBs, but we have specific drugs that can help slow progression of diabetic kidney disease. So another major advance was tolvaptan for polycystic kidney disease. And a nice New England Journal paper, this was from the TEMPO trial, and subsequently there was a second trial, the REPRISE trial, published only 3 years ago, where they found that tolvaptan actually slowed progression both in early and late stage autosomal dominant polycystic kidney disease. And you can see multiple studies. Clearly, you can see all the means here on the right side that they favor tolvaptan compared to placebo, whether it is factor in for age, sex, race, baseline GFR, stage of chronic kidney disease, and so on. So clearly a remarkable something that we can offer our patients with polycystic kidney disease. So there are some caveats to this. Yes, it slows kidney growth, it reduces the eGFR decline, it delays recovery and need for renal replacement, it reduces pain, hematuria, and stones and UTI, and it also reduces blood pressure. But it has some side effects. Patients have to get up at night to drink water because they have, and also causes intense thirst and fatigue and nocturia. The uric acid levels can go up. It can cause liver toxicity. And right now, at least, it's expensive because of patent, and royalty issues. So here's just a flow chart, an algorithm for how you should use tolvaptan. It is not for every patient with polycystic kidney disease. Currently, the recommendation is to use it in patients that have rapidly progressive polycystic kidney disease. You want to make sure that their liver function is monitored carefully, that you exclude all those reasons why you should not use the drug, and then carefully monitor the response to therapy. This is a very recent finding on protein translation in sepsis-induced AKI. I know you all work in intensive care units, and the commonest cause of acute kidney injury is in the setting of sepsis, where these patients have, hypotension, bacterial load, cytokine storm. They've received a lot of antibiotics and so on, and they get acute kidney injury. That's associated with high mortality and morbidity. So these investigators from Indiana University showed very nicely that they found an antiviral response in bacterial sepsis and how it shut down protein translation within the kidney. So this is just a figure showing their key data that when you have sepsis, all these proteins at 0, 4, 1 hour, 28 hours are massively turning around. So these proteins are making new proteins. But at 16 hours, you see very little proteins that are being made. So there is a shutdown in these protein synthesis. And it was found that a lot of these proteins belong to this family of E1 elongation factor 2 alpha. And when you inhibit this pathway, you can actually reverse this protein translation inhibition and actually improve outcomes in sepsis-induced AKI. So I know they're looking at doing clinical trials targeting this pathway for sepsis-induced AKI. So we've got a lot of different new therapeutic targets that are mechanism-based for treatment of that we didn't have anything else to offer our patients other than just dialysis. So hopefully I've shared with you, we've made great progress in the past decade with nephrology. We've got a lot of new diagnostics, precision medicine and mechanism-based therapies. There's a lot to look forward for us in the future of nephrology. The NIH has this large kidney precision medicine project that is ongoing. The ASN has embarked upon a very ambitious prize competition, Kidney X, and we just gave out 6 prizes last month to winners to redesign dialysis. And 5 of those 6 are actually biomedical engineers. So really remarkable progress along those lines to bring innovation in our field. So hopefully what I've summarized here is just a few examples of those major discoveries that can reshape our field and increase interest in nephrology, at least in the US. And hopefully you'll be able to share these experiences with your residents and fellows. I'm happy to share these slides with anybody. I can email to Dr. Vincent and others, and they can share them with each one of you that you can use to share with your medical students and maybe even undergrads and others, so we can attract talent, to our field. Thank you again for your attention. I'm really open to questions over the next 20, 30 minutes.
Oh, thank you, Dr. Agarwal. That was very, very good presentation, very comprehensive. We really appreciate for your time in making this good presentation. So it's the time for questions or comment. Maybe I should start with my one of my questions. Dr. Agarwal, about the NAD or NAD metabolites by synthesis, niacinamide, in the treatment of acute kidney injury, AKI. So at which stage should we use niacinamide? Is it available in the market? How effective it is?
So in the US, you can buy it from a grocery store. Okay, I don't know in Africa, in the continent of Africa, what the situation is, whether you can buy it over the counter. You don't need a prescription for it. But I think what they're doing is, right now you have to use a little higher dose. And I know Dr. Parikh's group is doing some more detailed studies to see if they can improve the formulation so there is better bioavailability. So you can use lower doses of the drug. So it's still in clinical trials. Okay. They have to do it on their own because no company would be interested in taking this on since it's already available over the counter as a nutraceutical. So we don't use it routinely yet. I think we need more studies, but the initial studies are very encouraging based on the results that I presented.
All right, thank you. So it can be used in any stage of AKI?
Correct.
All right, thank you.
Thank you, Dr.
Any other question? Yes.
Dr. Barakali is asking, can you kindly elaborate on the NIH Kidney Precision Medicine project?
Yes, so NIH embarked on a very ambitious project. It's called the Kidney Precision Medicine Project. So essentially, they are biopsying patients with AKI and CKD and doing very detailed analysis at the molecular level, at the single cell level. The kidney has 60 different cell types, each cell with a different function. Until we know what each cell type really does, we cannot just develop a therapy. And we know that, glomerular disease affects, podocytes and mesangial cells and endothelial cells, and AKI affects tubular cells and the endothelium. So to really understand that, they're developing a human cell atlas of the kidney. Hopefully with biopsying humans with AKI and CKD and doing detailed single cell analyses, whether it's transcriptomics, metabolomics, and proteomics, as well as very informed, informatic approaches to find out what does the kidney atlas look like in the humans. And hopefully that would enable us to understand the kidney a lot better and open up new targets that we don't know about, and maybe come up with even more newer therapies for various targets that would be identified. It's a lengthy project. It won't occur in a year or two. It'll take at least 8 to 10 years to get all the data. Similar studies have been done in the brain where they developed a brain atlas. And there are some studies looking at the lung as well as the skin. So some examples where work is already being done. So I think that is absolutely clear. So there was a question on sepsis and AKI. And in addition to dialysis, what else can we do? That's a great question. And unfortunately, right now, we don't have much to offer our patients with sepsis-induced AKI, apart from, limiting contrast, making sure their blood pressure is fine, limiting any nephrotoxic agents that they can get. Dialysis and timing of dialysis is another big issue. And right now, the indication is, dialyze when you have indications for dialysis. We unfortunately don't have any remedies right now for sepsis-induced AKI in the ICU, apart from supportive management in the form of dialysis. Dr. Kisoka asked that question. So,
thank you, Dr. Agarwal. A question for myself. Bearing in mind the benefit SGLT2 inhibitors have shown in diabetic kidney disease and now in in prevention of cardiovascular outcomes in non-diabetic patients. Do you think we'll have a scenario where we'll try to prevent renal outcomes in non-diabetic kidney disease? And where we did throw your money on, which one will be the first? Is it proteinuria kidney diseases, a particular glomerulopathy that will benefit from this agent?
Yeah, it's a great question. I think, most people do diabetic kidney disease because that's the commonest form of, kidney disease. If you go to a dialysis unit, 50% of them have diabetic kidney disease as the underlying cause. There's been a lot of work through NephCure in the US for nephrotic syndrome. So there's work on FSGS because that's one of the common causes of nephrotic syndrome in the adults. There's a lot of work now on Alport syndrome. It's turning out that a lot of patients that are labeled as chronic kidney disease may actually have an underlying genetic cause if you do genetic studies on them. And at least less, even like if you have thin basement membrane disease or benign loin pain hematuria syndrome, you biopsy them or you do genetic studies, they end up having Alport syndrome. And there's been some work now with bardoxolone that may be beneficial in those patients with it had shown some promising results in diabetic kidney disease, but had some side effects because of the dose. And it was essentially shut out, from several years ago. But that has reemerged now for Alport syndrome. So I would think for proteinuric kidney diseases like membranous, FSGS, clearly, we need more mechanism-based therapies. Even for minimal change disease, right now we just have steroids and cyclosporin or cyclophosphamide, or for rituximab is coming up for a lot of but even rituximab is not very specific mechanism-based therapy, just shutting off your B cells. So I think we need clearly kidney-specific drugs that can benefit, but I think the human cell atlas will help enable that work.
Thank you. A question about concerning the new concepts for potential future of hemodialysis. I don't know if you'll be able to answer this, whether you can share.
Can you speak up a little bit? I cannot hear you well.
Hear me now?
Yes.
Okay, sorry. A question from Dr. Amar concerning the concepts for the potential future for hemodialysis. Can you share some of what the prize winners from last month have in their pipeline? I don't know if you have.
Yes, yeah, definitely. So if you go to the website of the ASN, all their presentations are online. Very brief presentations from July 25th when they accepted the prizes. It is very impressive and just you get goosebumps, when you see those presentations. And I think these are freely available. You don't even have to be a member of the ASN to, view those slides. I think what a lot of them are looking into dialyzers that can be implantable, so you don't need a needle, to do 3 times a week. A lot of them are trying to develop artificial dialyzers with human cells within the dialyzers. There's a lot of improvements in vascular access that can limit AV, fistula restenosis or graft restenosis. So they're doing drug delivery systems with nitric oxide and things like that that can deliver nitric oxide and prevent restenosis. Because if patients have vascular access, that's their lifeline, right? And if the access keeps getting stenosed, then you have to do multiple procedures on them. I'm sure you're familiar with taking care of that in your dialysis units. So a lot of those pertain to artificial kidney, implantable dialyzers, and improving vascular access related issues.
Okay, thank you very much. Another question on SFLT1 inhibitors. I hope you can hear me well now.
Yes, very well. So the assay is still a lab-based assay. They have an ELISA that has been developed, and I know they're doing large-scale, clinical trials with it. It's not a lab test you can order just like a BMP right now. It's still an experimental, you can measure it, but it's not routinely being offered currently.
Maybe if I extend that question, SFLT1 has got similarities with BLA2 receptor antibody, being a biomarker and testing for possibly disease activity. How come after all those years of us knowing about it, there hasn't been much development as fast as for BLA2 receptor antibody developments have occurred?
Science takes a long time for it to get validated and so on. So to give you an example, the renin-angiotensin pathway was discovered in the 1880, 1890, okay, more than 140 years ago. And we got ACE inhibitors and ARBs only 1980 or so. So it takes a while for things to occur. I wish it was not the case. We need a COVID vaccine like yesterday, right? To get an end on this pandemic. But it takes time for, to do things carefully and slowly. And in the US, it's even more difficult because of the bureaucracy and all the regulatory burden that we have, to jump through hoops. It's a lot easier in Europe and Asia that I know. I'm not sure how things are in Africa in terms of moving things along. Once there is a important discovery, it just takes a long time for those things to occur. I wish it had occurred earlier, but it's clearly not the case. So,
question regarding the implantable but artificial kidney for end-stage disease. What are your views?
So that, there was one for acute kidney injury that David Humes had actually developed, and it looked promising in initial studies, but there were some side effects in some of the patients that were selected. So essentially it, went on the back burner. But one of the projects is re-looking at that to really see if that artificial kidney can, really be developed further. There's also effort with 3D printing. A lot of folks are now printing organs like the trachea, the urethra or the bladder, that you can essentially do 3D printing. And I'm sure in our lifetime, we will see where you can just order a kidney and say, I want a kidney that has, 1 million glomeruli, 10 centimeters by 8 centimeters, and essentially it gets printed in a shop and you just use that for transplantation. It is in works, but is not ready yet. But I think there will be a day in the next 10, 20 years that would be the case, or we would have xenotransplantation and so on. But I think significant progress is being made, I think, with the implantable artificial kidney device. So
maybe I can go back to my question on SGLT2 inhibitors. Do you think there'll be a time when they'll be used for opportunity?
So SGLT2, I'm sorry, I didn't hear you well. So I was thinking you were talking about the SFLT1 for preeclampsia. SGLT2 inhibitors are being used routinely in the US now. Nephrologists, endocrinologists are prescribing it now. in fact, patients are asking us, why am I not on a SGLT2 inhibitor? So we are prescribing it now routinely for diabetic kidney disease patients. So I think studies are ongoing, and hopefully at this ASN, there may be some presentations on effects of these inhibitors on non-diabetic kidney disease, FSGS and so on. We may see some early results, hopefully. So I think they have promise beyond, just through their effect on, inhibiting the sodium glucose transporter in the kidney.
Okay, from Dr. Sandip, he's asking about polycystic kidney disease. Which patients are eligible? I think you had alluded a little bit to that. Maybe you can expound more.
Yeah, so the question was to expand more on which patients are eligible for polycystic kidney disease treatment with tolvaptan. So right now, anybody who's rapidly progressing or have a history, the patients who progress with PKD usually have a strong family history of progression. So you can essentially predict. So you monitor them every month or every other month, and you see their kidney function rapidly, declining, or the kidney size is rapidly increasing, have significant pain and so on. Those are the patients that benefit from tolvaptan. You want to make sure they don't have any underlying liver disease that contradicts them. You want to monitor also the uric acid levels because your uric acid can go up and you can get gout and so on. So those are two things that you want to monitor. So rapidly progressive patients, they are the ones that benefit the most from tolvaptan. So not every patient with polycystic kidney disease should get tolvaptan because it's expensive. And I'm not sure, is it available in Africa?
Yes, it is available.
Yes, it's available.
Okay.
Yeah.
So I would just be careful in what patients give it. We have a big PKD center and we have a PKD clinic that we see all our patients. And even in that clinic, I would say a third of them are on tolvaptan. So we are highly selective in who gets tolvaptan, and more importantly, who doesn't get tolvaptan, because it's not supposed to just, to give it to everybody.
Okay. So people can't hear me. Can you hear me now?
Yeah, much better.
Yes.
There's a problem with my earphones. Right, I'm checking if there's any other question that has been posted since then. From Dr. Lloyd Vincent, has SFLT1 looked at any other clinical conditions apart from in preeclamptic pregnant ladies?
Not that I'm aware, Lloyd. I'm not sure if it's being tested in any other conditions. I know they were looking at HUS TTP because that's also a microvascular disease. But the big source is really the placenta. So I'm not sure if they've looked at other conditions as much as they did in preeclampsia and pregnancy.
I have one question. Just one question. You see, coming to COVID, we've had a lot of mortality that we see in the US. Of course, I think there's a lot of difference between the US and in Africa. But in Africa, the mortalities are really limited, you see. And one is, I would say, of course, the mean age is less. The population densities are less. But there's one major factor, especially in East Africa. We have a lot of zoonotic diseases here. So do you think that could be a cause, or would you like to highlight if you think there are any other things that could potentially play a part here?
That's, I wish we had the same here. And I think, the population density, clearly we are seeing that in some states in the US where the population density is not as high, like in Montana or, North Dakota or Wyoming and so on. There is not a huge disease burden. So I think the population density is, I think, important. The other thing is also social determinants of health. So we are seeing that in the southeastern part of the US, also states like Arizona, Louisiana, Mississippi, Alabama, Georgia, South Carolina, that the disease is much, much, higher burden and more importantly, vulnerable populations like Latinx, African Americans, the diseases, even the incidence may be the same, but the complications and the mortality level is twice as much as Caucasian Americans. So whether they have more underlying conditions, obesity or kidney disease, not sure why, but that is huge. The disparities with COVID is huge in those populations, Lloyd. So I don't know why that is the case. And apparently in other countries, the disparity is not as much. It's probably because the US is an immigrant country, right? You've got people from everywhere. And is that the reason? I am not sure. And maybe the populations in Africa are more uniform, therefore the genetic, maybe the herd immunity is different. I don't know. So your hospitals and all are not getting flooded with COVID?
No, it's not. In fact, COVID is no longer there actually in Tanzania. I don't know what's the situation in Kenya, but certainly not there in Tanzania. And we are all off the masks. In fact, most of us are off the masks.
Wow.
Yeah, so that's a big relief. And it looks, if this is a situation likely even across the world, it should come down. I don't know. There would be other opinions as well, but certainly a big relief out here. And the other thing I find is, of course, there's a distinct difference between AKI and CKD that we have with COVID. AKI is definitely much more severe disease, but in CKD, actually you get them out early, and the immune response, if you're able to blunt the immune response early, these patients actually come out very quickly, and especially. Yes. Can you give us your opinion, Anupam?
Yeah, I'm not sure why. Maybe the patients with CKD have some level of immune suppression, right? And how they respond to that is different than a normal person that has a massive cytokine storm. It's an immune activation syndrome. The ferritin levels are very high in these patients, right?
Yes.
So is the ferritin protective, right? CKD, your ferritin levels go up. Is it the ferritin that is, causing this? So these are all hypotheses that have been put forward. So there was a question on radiology, the role of radiology in determining use of tolvaptan. I think absolutely. Either ultrasound or MRI to measure kidney size for progression. That is a well qualified method to monitor progression of kidney disease. So if you have a way of monitoring kidney size by ultrasound, I think that's clearly a role, for monitoring, and also whether or not you should use, for giving tolvaptan. The other question was SFLT1. Is it practically used for diagnosis? No, not yet. It's still a research. I cannot order SFLT1 just like I can get a BUN or a creatinine as yet. So. I think I've addressed all the questions.
Yes, Doctor.
Coming up on trypanosoma.
Yes, we can take one more question from the audience, and then that will be the last question.
Yeah, Dr. Haruna from Rwanda. Hello?
Yes.
Yeah, no, I'm sorry. Let me take, could I take, okay, I'd like to thank Dr. Agarwal for this good update, actually. I feel modernized now. I'd like to take him back to the use of tolvaptan in management of polycystic kidney disease. Now, is there role for the other blockers other than tolvaptan in management of this pathology?
I did get the full question, Joseph.
Yeah, I am saying you mentioned tolvaptan in the management of autosomal dominant polycystic kidney disease.
Yes.
Now, is there a role for the other B2 receptor blockers like tolvaptan and so on?
Yes.
In the management?
Yes, I would think so. You need to continue using other measures like control of blood pressure and so on, absolutely, with ACE inhibitors and ARB, because those should not be stopped, in the process. So There was one of the.
The other V2 receptor blockers.
Pardon me?
The other V2 receptor blockers like lexibaptan and so on, are they also effective?
Yes, yes. I think any vasopressin, receptor antagonists are effective. The one that's being studied extensively is tolvaptan. I don't know about conivaptan and others, but the clinical trial has only been done with tolvaptan as far as I know.
Thank you.
There's a question on trypanosoma, whether it's protective in AKI. I don't think that has been studied. It's only been studied in the context of, chronic kidney disease. I am not aware if it's been studied in AKI. Yes, so tolvaptan is used for hyponatremia, but it's expensive. And that has precluded the cost in the US. We do use it for hyponatremia. It's the same tolvaptan, you're correct.
All right, if there's no any other question, maybe we can take one comment from Dr. Vincent Lloyd.
I'll just add that, feel free to email me. I'm happy to send you my presentation, or, also would love for you all to participate in the annual meeting of the ASN. It's in October. It's a fully virtual meeting. All the plenary sessions and the major late-breaking clinical trials will be freely available for everybody in the world. So please consider signing up, and we would love to see you all participate in the meeting.
Right, thank you, Dr. Agarwal. Dr. Lloyd, one last comment.
Thank you very much, for the excellent exposition of so many things that we actually don't see out here in Africa, and it gives a lot of food for thought for the youngsters. And the most important thing that you pointed out was, encouraging the youngsters to come up, and that is key, because they are the next generation, and exposing them to this high quality medicine makes a lot of difference. And that's a very, very important point that you brought out. And that is the key reason why we actually would love people like you coming out and talking, because it exposes the youngsters in Africa to the world outside. And the other thing is, of course, we are very grateful to the ISN for actually extending their support into Africa. They are doing a lot. We wonder if the ASN as well can do something. It's great that you mentioned about these talks at the ASN. This is really wonderful. Is there something that the ASN can do into African countries? I mean, in a very structured format, in terms of education or whatever, research, because there's so much of work that can be done in Africa as well. What are your comments? And thank you very, very much for coming on, taking your valuable time and talking to us today.
Lloyd, I would be delighted to work with Africa through the American Society of Nephrology. We are a global organization. We have 23,000 members from 132 countries. We do a lot with, obviously with ISN, ERA, EDTA, with multiple countries across the globe. So I'd love to see a proposal. Send me something, and I will make it happen during my presidency year. Whether it's educational activities, research activities, if you all want to get together and send me something, I will act on it and deliver that for you all. So we will all benefit from this.
Oh, excellent. Thank you very much, Anupam. Definitely we will come up with a good proposal, getting everybody together, and I'm sure we will get to something really good.
Okay.
Excellent. Thank you so much.
All right. Thank you all. Take care. Bye-bye.
All right. Thank you, Dr. Agarwal. Bye.
Have a good evening. Bye-bye.
All right.